So in terms of disclosures, I don't have any disclosures to make in terms of a financial arrangement related to the content of this activity. Today I'll be presenting on cognitive behavioral therapy for relapse prevention with a specific focus on mindfulness-based relapse prevention. And I want to make sure to give credit to Dr. Lindsay from UNM's ASAP clinic, who developed the slides that we then adapted this presentation from. In terms of our learning objectives today, first is to describe classical conditioning as it relates to substance use, then to provide a brief overview of cognitive behavioral therapy, CBT, the components and the interventions as they relate to relapse prevention, RP. And then we're also going to review representative interventions from mindfulness-based relapse prevention, or MBRP, which is a particular type of CBT for relapse prevention. And I want to take a moment to just clarify, because I know for those of you who have been on the ECHO for a while, you know we've always championed CBTRP. MBRP is really not a big difference. It's just a particular subtype of CBTRP that we wanted to give a little spotlight to, because in the past we've had people ask for training in CBTRP, and that's a lot harder to access than is training for MBRP. It's kind of the newest thing. There's a lot of recent research in it. It's a lot easier to get virtual trainings. So that's why we chose to just spotlight MBRP. Right, so we'll start out with talking about where relapse prevention skills fit in the stages of change. If we're thinking about people really early in recovery who are in pre-contemplation or contemplation, so in other words, not really thinking about change or really on the fence about it, there's really nowhere for these skills to land at that stage. Where the money is, where there's a lot of room to land, is at the stage between action and maintenance, where the patients are already taking steps, they're carrying out their plans to change their old health habits, and they have something to protect. They have skin in the game at this point. The relapse prevention skills really help them to protect what they've already done in order to change their health habits. And it really smooths the path into that maintenance stage where they can be sure that they have the skills to keep on with the new health behaviors and to stay away from the old health behaviors. So we'll back up and just look sort of big picture. What is cognitive behavioral therapy in general? CBT is the therapy that addresses the links between thoughts, feelings, and behaviors. And we'll see in the diagram in a minute, those links flow in all directions. CBT has shown good evidence for treating really a very wide variety of mental health concerns, including all types of substance use disorders. It has by far the widest base of research literature compared to other psychotherapy approaches. And it also works with dual diagnosis, which of course is really important with this population. It's very flexible, it's very agile, so you can implement it in a lot of settings and contexts. It's very short-term and highly focused, so you can see why it's very popular both for research and in primary care and hospital settings. So in terms of a conceptual map of how CBT works, you can see here that cognitions, behaviors, physiology, and emotions are all linked with these bidirectional arrows, meaning that intervening at any point is going to change the general flow throughout that whole diagram. What we know from research and from personal experience for most of us is that acting directly on emotions or physiology is very difficult in most cases and very often impossible. So CBT, as the name suggests, really focuses on intervening at those junctures of cognition or behavior in order to change the flow in all directions. You'll see that in this particular diagram that the environmental component or the activating trigger that gets this cycle going is located on the outside of the system. And that's really more for sort of teaching purposes. I do really want to underscore that, especially for this presentation for substance use disorders, a trigger can very much be internal. It's not necessarily something that's coming from the outside environment. It could be a memory or a feeling. We'll talk more about that in a bit. But as a very general kind of vague example, the idea here is that if you had some kind of an activating event, say your boss puts you on the spot at work, maybe a thought comes up that's anxiety provoking, a thought of, oh, I'm not going to do well, I can't perform, I'll look dumb, people will judge me. That leads to more negative emotions like fear or shame or anxiety. That in turn can precipitate a physiological response like increased heart rate or blood pressure, flushing, sweating, trembling, none of which makes performance very easy. So that can translate to a sort of self-fulfilling behavior where somebody's trying to just escape the situation or minimize it. So they're maybe making excuses or fumbling or generally not behaving in a way that's best for their purposes in that situation. Whereas with plenty of CBT or mindfulness CBT training, When we can just recognize that thought the moment it arises, then we can choose a different path. We don't have to just get sucked into that thought of this isn't going to go well and all of the sort of unhelpful actions that follow. So it's a very brief summary. I think you'll see a little more clearly as we go through how it works. So let's focus now on MBRP for a moment. So again, it's just a subtype of CBTRP. In fact, it's the same co-founder for both of them. And it's just CBTRP that integrates mindfulness practices. It was specifically developed because the research shows that cravings and negative affect very specifically play an outsized role in the relapse process. And these are two of the components of the relapse process that mindfulness very specifically targets. So some of the big principles in MBRP are awareness, the idea of noticing on purpose and in a particular way is the phrase that is often used. What goes along with that is responding rather than reacting to all kinds of situations, but particularly challenging ones. The idea there is that the default for most people is to go into a kind of automatic pilot mode and respond reflexively when difficult situations arise. And that when we can incorporate these mindfulness processes and become more deliberate about observing what's happening with us and in the situation, then we can choose purposefully and make choices that reflect who we want to be and what's best for us and others in the situation. This also goes along with changing our relationship to discomfort. For a lot of us in Western culture, we were raised to just implicitly think of discomfort as a negative thing to be escaped or suppressed or minimized. When we can learn a different way to sort of make space for it, to be curious about it, to even invite it in, it's quite a lot less threatening. It takes a lot of the sting out of the discomfort itself. And again, it allows us a lot more sort of flexibility for that piece above of responding rather than reacting with a sense of urgency. An important substrate for this is self-acceptance and self-compassion, as well as compassion for others. Especially early in recovery, people tend to be very self-critical and want to sort of punish themselves into cessation. We know from the research that that almost never works for most people, and that being able to accept that things aren't going to go always as you planned, and you may not always live up to your expectations in this process. It's going to help you out on a pragmatic level. It's going to feel better, and it can be nice to remember that we're just all part of the human race, and we're all flawed, and we're in good company in that way because it's hard for everybody to change health habits. And then lastly, lifestyle balance is really more of a global idea. So that's about both having a wide variety of mindfulness and other practices to take care of ourselves, as well as taking more of a global view or an aerial perspective. So that sort of observer stance when we look at our lives and think, what is the best way to take care of ourselves long term rather than just for this particular moment? So some general considerations in practice for CBTRP. First of all is the importance of repetition. That's not only because prolonged substance use is likely to cause cognitive deficits, that's a significant consideration, but also just the nature of substance use, if it's chronic, is that it's deeply ingrained. It's really carved a deep channel in the brain. So it takes a lot of time and effort and repetition itself to carve a new pathway. And this is an important piece of psychoeducation for both providers and patients, because without it, we tend to default to thinking that repetition is a sign of failure or that treatment is not going as expected, and that's not the case. This is very much part of the course of treatment for CBTRP. Second, and this is true of any kind of CBT, is you want to provide a very clear rationale for the activities that you assign between session. We know about CBT unequivocally that the most important engine of change with this approach is what happens outside of session. So it's how patients apply those activities and skills that you've gone over in session. So you want to make sure that they're leaving session every time with a very clear understanding of how the activities that they've been assigned are going to help them reach their larger goal. Some of the activities can seem obscure, especially if they're early in recovery and new to treatment. So you want to be really clear to break down, this is how this activity is going to help you, and to troubleshoot anything that they're concerned about with it. This goes along with monitoring how they're practicing outside of session, also true of any type of CBT, but it's both because you want to make sure that you're offering that troubleshooting in the office, that you're identifying any issues with resistance, again, where they're maybe not understanding, or issues with confidence or logistical barriers. It's also because you're constantly meta-communicating that really important point that change is going to happen based on how they apply these skills outside of session. That's how CBT works, and if they don't understand that, then they're unlikely to succeed. So really, really important to communicate how essential that outside of session practice is. And then lastly, and this part really is my favorite, is praising successive approximations. Successive approximations just means a very small unit of a larger behavior. So if maybe the larger behavior is, cessation of use, very small behavior, successive approximation would be, for instance, taking a different route home from work so that they were not driving near their dealer's house. They might still end up using that day. There might be other things that don't go as planned, but that is a really important smaller unit of behavior that contributes to the larger behavior. You want to really, really be the cheerleader for those and make sure they're recognizing all the little steps that they're taking that eventually coalesce to the larger behaviors of recovery. So we're going to step now to the conceptual side more. Triggers are a very important foundational part of understanding CBTRP, and that's about really identifying and thinking through both the external and the internal triggers for the urges to use, so those thoughts, and then if they're not interrupted, the using behaviors themselves. So the way that I like to conceptualize it, it just kind of makes it simpler for me to keep track, is to think of how each component here, the trigger, the thought, the craving, and then the use, are connected in a link of chains, and you can cut that chain at any point, but it's much easier to cut it higher up than lower down. So really, the further upstream you can get in interrupting the sequence of events, the more time and effort it's going to save the patient. So when there are cases where a patient can just entirely avoid a trigger by planning ahead of time, and it's not going to decrease the quality of their life, or have any other kind of significant detriment, do that. That's a really great intervention in itself, and we'll talk more about that in a bit. However, when patients get really consumed with just avoiding all triggers, their world gets very, very small, and they can get cut off from the people and the things that they love. That carries its own risk, of course, for relapse as well as other mental health conditions. So it's really important to do both, to teach them how to spot and avoid triggers when it's easy and accessible, and then how to interrupt at each link down the chain, preferably as far up as possible. So let's look now at some techniques for doing that. We're going to start with just an overview of classical conditioning. I think most people at some point have heard about Ivan Pavlov's classical conditioning experiment, where he took dogs who had just the normal unconditioned response to food, which is salivation. All dogs do this, no matter where they're from or what kind of dog they are. And he paired that with a previously neutral stimulus, meaning a bell. So the dogs had no preconceived notion about what a bell meant. They just heard it. They had no other kind of behavior or reaction. And then over enough time of pairing that bell with the food, the bell became a conditioned stimulus where the dog would hear it and start to anticipate that unconditioned stimulus of the food. And so their body was reacting as though the food was already there. They were, in a sense, having an urge, having a craving, and their body was preparing to eat that food, even though there was no food present. So I think that the implications here for the development of a substance use disorder is probably self-evident, but I think it's also helpful to tie the theory back to this really important conceptual underpinning, both to understand as a provider what the interventions are about, but I think also importantly as a provider to develop a sense of empathy about how difficult this can make daily life for people who are new in recovery. Because the thing that we know that's very different between dog food and illicit substances is that illicit substances are incredibly potent and fast acting. And that means that in terms of forming associations, forming these kind of conditioned stimuli, they're very sticky. They'll just grab onto anything that's in the environment internally or externally, sometimes even the very first time that a person uses a substance. So things that might seem very innocuous to us, like lighting or music or the sound of someone's voice, that can be a really, really strong conditioned stimulus for a person in recovery that starts off that craving and that urge chain. So just remembering, it's really hard without getting to know a patient well to just identify their triggers right off the bat, because the number of triggers that exists are basically as infinite as the individuality of human experience. So that's a very important part of the CBTRP process, is helping patients and helping you as a provider to recognize all those triggers. So how do we do that? How do we apply classical conditioning theory to treatment? Usually the foundational step is using the functional analysis, where we're looking at people, places, and things so that we can make those triggers explicit, really map them out, as well as the high-risk situations, which are sort of collections of triggers. We're also going to examine the short and long-term positive and negative respective consequences of substance use. So that's both understanding why they use and why they would want to stop using. And then from that map, from that functional analysis information, we review and develop positive reinforcements, which are called behavioral contingencies, and meaningful alternatives to substance use when the trigger is present. I'll show you what that means in a moment here. So this is the most basic form of a functional analysis chart. You see the first two columns are external and internal triggers. That's where you spend the most time early in treatment because that's going to form the foundation of most of the other skills. As the patient becomes more fluent in treatment, you're going to spend more time on those latter two columns of short-term positive consequences. So that's when they get down to it, what is it that they really do like about using? And sometimes the answers will surprise them. And then also the long-term negative consequences. So in other words, why are they trying to change? What is not working for them about their present substance use? So you can see, it's kind of simple in a way, but you can spend quite a lot of time on these over the course of treatment, and it can really illuminate to the patient a lot of the factors that have been unconscious to them in terms of what's leading to their use as well as why they're using in general. Something that I always just want to underscore because I think it's easy to forget is that the formula for addictive potential is something that has a rapid, potent, positive consequence. So it's like the good things about doing it are really right there in your face and they happen right away, paired with negative consequences that are vague and off in the future and diffuse. That is the ultimate recipe for addiction, and that's exactly what illicit substances do. So out of all kinds of ways that we form habits, illicit substances, unfortunately, are just extraordinarily good at this. And that's important to communicate to patients as well when they feel, why am I not making more progress? Why is this so difficult? Well, unfortunately, illicit substances are really very much engineered to hang on in this way. So taking the mindfulness lens for a moment here, one of the interventions that we use at this stage that we pair with the functional analysis is called sober breathing. And what I like to visualize with patients, and this is in the manual, is an hourglass in terms of how we guide our attention, starting very wide, then narrowing in the middle, and then widening out again. So you can visualize that as we go through these steps. The first is to stop or slow down. So the default mode for most people is if you're in a stressful, risky situation, to have that sense of urgency and to just kind of be sucked into the flow of it. And so you're doing the positive opposite here. You're going to just hit the brakes and you're going to step back for a moment and you're going to check in with what's happening with you and with your environment. So that's the first step of stepping out of that automatic pilot. You're just bringing your awareness to the experience in the moment. From there, you're observing what's happening, observing your body, your thoughts, your emotions. You can see the attention narrowing here. The narrowest point is where you bring your attention just to your breath. So you're leaving the rest of the world there. You're just focusing on the sensation of breathing. Then you slowly start to re-expand your awareness to include your body, your experience, the situation, ideally holding it all together in a larger awareness. And then lastly, you're responding, going back to our earlier point, rather than reacting, you're responding mindfully and purposefully, where you have that kind of larger context from the former steps of what's really necessary in this situation, what's the best thing for me to do to take care of myself and others and to be the person that I want to, rather than going with whatever the habitual mode of automatic pilot dictated before. This is a speed run through sober breathing. If I were introducing it to a patient, it would take the larger part of a session. So let's move now to behavioral contingencies, which are an important next step in terms of how we apply the functional analysis. And this is how we understand the connections with urges to use and then the translation to the using behavior itself. So for the purposes of this presentation, we can think of positive and negative consequences as, a positive consequence being a reward, negative consequence being a punishment. Technically, it's not nearly that simple in psychology, but for the purposes of this presentation, makes it much easier. And remembering that rewards increase desired behaviors, whereas punishments decrease undesired behaviors. And the big headline here is rewards are always more effective over the long term. What we know is that punishments, for the most part, are just temporarily obscuring or suppressing undesired behaviors. Whereas when you are actually increasing desired behaviors, it's not just that you're helping to teach new skills, you're sort of out-competing the old behaviors. So you're giving them new ways to live. While also extinguishing the old ways. So the rewards really are, unfortunately, it's antithetical to kind of the cultural stigma, which says we can punish people and to stop using. We know from the literature that's not true at all, but that is that anachronistic way of thinking, and it's important to educate patients about why this is actually more effective. So in terms of applying contingencies on this echo, we've talked a lot about contingency management. So that's a very formal system of applying contingencies, but you can also do this in a more flexible way if you don't have the resources for formal contingency management. Behavioral targets are usually the best. So choosing something that's fairly objective, something that you're pretty sure you can define in advance and check, fairly. So attendance is a good one. Abstinence or a reduction in use as verified by UDS are good ones. And then you pair it when a person meets that target with a reinforcing consequence or a reward. So that could be anything from money or vouchers to privileges like take-home doses to things like public acknowledgments or reinforcement from the provider or the family. And one thing we really know from contingency management is it's very important to check with the patient about what's going to be reinforcing for them because it's highly individual and providers often get that wrong. So what goes along with formal contingencies is this idea of how do we take care of ourselves, a different kind of a reward. Because for a lot of people, the way that they were led into substance use and the way they've maintained it is in a sense, taking care of themselves during difficult situations. So we want them to learn these new behaviors of, how can they take care of themselves in ways that are more sustainable and better aligned with their long-term plans. So you have the trigger situation and the positive consequence that goes along with it, and then the alternative activity that has a similar positive consequence. I really want to emphasize here, it's not going to be the same in proportion or magnitude to an illicit substance. Those activities don't really exist as far as I know. But what you're teaching them, and you really want to articulate that so that they take you seriously, is that you're teaching really a paradigmatic shift from this is something that's going to work right now in the moment to take away this bad feeling, for example, versus this is something that I can sustainably do long term to start to chip away at that feeling and the causes of that feeling so that over time I don't even need to worry about those use behaviors anymore. I'm just going to be taking better care of myself in general and feeling better so that I don't feel that need so much or feel so vulnerable to it. An equivalent here in MBRP is the relapse cycle worksheet, and this is a little complicated, so I'm going to really summarize it. You can see the first two steps there are labeling the trigger and then the initial reaction. So just noticing first what is the trigger, what follows it, and then you can see it forks into a decision tree. The bottom tree is the old way, so that's defaulting to automatic pilot. And a representative cycle here is, having a thought that then leads to the automatic reaction of using, which then leads to more thoughts and feelings, often guilt, shame, that sort of thing, that feeds into a recursive loop of further use. The upper decision tree is to stop, hit the brakes, initiate that sober breathing if they have that skill yet. And you can see those components there that harken back to the sober breathing, where you're really just observing before you make a decision. You're taking, your own self as well as the context into account, and then you're mindfully choosing a response. Something that's interesting about MBRP is that you're not necessarily trying to get them to not use substances at the end of this. The emphasis is really on a different pathway, is that rather than just defaulting to use without thinking about it at all, that they are observing and making a purposeful choice about their response to a trigger, because it's that practice that is the larger, more important piece for ceasing use ultimately. So now we'll spend a little time on urge management, another important conceptual substrate here. So that's about understanding how to identify and modify the urges, so the thoughts, before they turn into behaviors. The first step here is a log of urges. This is the most basic one, just the date, the situation, the intensity of the cravings, and then the coping behaviors used. Early on, that last column is probably going to be blank, so that's a good signal as a provider to start scaffolding in coping behaviors, helping patients to understand how they can take care of themselves as well as how they can just get out of a difficult situation. And the corresponding intervention in MBRP is the Noticing Triggers worksheet. And this is something that they're supposed to fill out every week. And they're noticing the situation and the trigger. It breaks it down a little more finely into the sensations, the moods, feelings, and emotions, and the thoughts. And then also, what was their response? So you can see same basic idea, but with much more of a focus on the mindfulness of the experience of that present moment with the emotions, the thoughts, and the experience. So urge surfing is a really popular intervention that's firmly rooted in mindfulness, and this is one that I find adolescents in particular tend to like. The visual metaphor is that an urge is a wave, just like a wave in the ocean, that they're gonna come up and they're gonna crash on the shore and then they're gonna subside back into the water. So essentially, if you can sort of outlast them, they will eventually recede. And the idea is that just like if you went barreling headfirst into a wave in the ocean, You're probably going to get knocked down off your feet. You know, the wave usually wins, and it's going to take a lot of time and effort on your part. Whereas if you can learn to sort of surf on top of the wave, you can literally ride it out. So the idea is really early in treatment, this can just be about delaying use. So just doing the smallest thing that's going to put a little more time between the urge to use and the actual use, because that's an important way to build that skill. And then later on, as they become more skilled, to just fully ride the wave. Important piece of psychoeducation is that physiologically the body can't sustain an urge for more than 30 minutes at the outside. So it will feel, and you want to reiterate that to them. I know it feels like it's going to last forever, and there's no way it'll go away if you don't use substances right now. But that sense of urgency is part of the whole, as part of the whole unfolding process. And that if you are able to just delay and write it out, that urge will in fact subside within around 20 minutes, 30 at the outside. You do, of course, want to be honest and say, yes, waves keep coming, and that's true for everybody in recovery. But the great thing is that the more they practice and the more effective they are at being able to write it out, the waves get smaller even as their skills get better. So they're becoming a pro surfer even while the waves are getting much smaller. So it's much easier for them. It is important to learn how to identify and label the urges as a step towards urge surfing, because that's just understanding where they come from and how to anticipate them is an important part of integrating that skill. So you really like to pair this when possible with the daily urges and cravings log. And the extra bonus there is they get to notice the cravings decreasing in intensity over time as they become more fluent with this skill. So high-risk situation planning, this is a great modular intervention for CBTRP. So even if you just have a few minutes and you have, you know, the patient is not willing or not able to attend therapy for long term, this is a really great just pull it out of your pocket in a few minutes. You can, without too much context, help them understand how identifying the context that's going to increase their risk, the cravings or the urges to use, can help them to plan, you know, what can I do to just minimize that situation? And then what can I do to cope with it when it does happen? So situations that involve triggers, so anything that's been strongly associated with substance use in the past, that's a high risk situation. It's generally not one single thing. It'll be a constellation of factors that are associated. And then, of course, on the other side, people, places, or things that have never formed any association with substance use, those are low risk situations. Sounds really simple, but you know, it's really a lot of mileage. If they can decrease their time in high risk situations and increase their time in low risk situations, it just really dramatically reduces their vulnerability to relapse. So you can really pitch it as this is sort of the lowest energy intensive way to avoid vulnerability to relapse. This is the most basic format for a managing high-risk situation planning worksheet. So it's just what's the situation that you think you might experience this week that'll be difficult, and how can you handle this situation? So they having the advantage here in talking through this with you in the safety of your office. They're benefiting from you having extra perspective, although you want to make sure that what they come up with is going to be accessible and appealing for them. And then they're going to carry this with them, because the important thing is you do not want them to have to improvise when the high risk situation hits. People early in recovery really do not have a lot of practice with this. It's very quick to go to default mode when things get stressful. So when you can, you know, to the extent that you can, anticipate and rehearse this ahead of time, and then have them carry it with them, physical piece of paper in their wallet, a picture on their smartphone, they're not going to have to make it up as they go along when they're already in a difficult situation. So a corollary here for MBRP is the using sober breathing space in challenging situations. And this, with MBRP, you're sort of doing it as you go a little more. Ideally, they're filling it out as they're in the situation, although I have not found that to be very practical for many patients. But you're listing the situation or the trigger. You're using that mindfulness lens to articulate what were your reactions. And then you're just checking, were you able to use that sober breathing skill or not? Yes or no? And then how did you respond? And there's no judgment if they weren't able to use the sober breathing space, or if they did and they still ended up using substances. This is really all about bringing awareness to it. And over time, they're much better able to anticipate what those high risk situations are. And most importantly, get to identify that those reactions, that second column, that is a cue for them to use that sober breathing skill so that they don't hit that default mode so quickly. So this goes along with another really concrete plan, or a concrete intervention, which is developing a plan. Again, it sounds so basic. Patients are sometimes indignant, so you really have to explain why this is so helpful. Very often people with chronic substance use disorders have never actually learned the skill of planning out their day. And previously they've expended a lot of their time on seeking and using substances. So in recovery, unstructured time is very vulnerable for them To the extent that you can fill that up with activities that compete with substance use, so spending time with people who support their recovery, or just spending time in activities that make it very difficult for them to use substances while they're participating in them. That's just a really, really simple way for them to be able to interrupt that chain very high up the stream. So sometimes you're getting really meticulous and planning it out hour by hour with them. And you're, again, they're there in your office, they're safe, they're thinking it through ahead of time. It's not always the case that they're going to carry it out as planned, but it gives them the opportunity to practice it. And you're really reiterating to them that the less time they spend in high risk situations and the more time they spend in low risk situations, the easier and smoother and more sustainable their recovery is going to be. So the corresponding intervention for MBRP is the reminder card. We fill this out in the 7th or 8th week. So that's the penultimate or ultimate session. First side, reasons to stay sober. So that's sort of that long-term negative consequence thing, what's in it for them to change. Then contact numbers, who supports their recovery that they can call in a pinch. Of course, we have the sober breathing space iterated there, even though by this point they usually have it memorized. And then also alternative activities and plans. So what are the things that they can do to compete with those behaviors or to use to get out of those behaviors once they start? So I do want to wrap up with sharing some MBRP resources. You can see here the first link is for background materials and trainings. The second is for recordings and handouts. And then I really want to spotlight the last one, which is a research, but also a free rolling treatment group. And that's actually at UNM. That's Dr. Witkowitz's lab. A really, really amazing resource. It's run by supervised graduate students, and it's available to any New Mexico resident that has internet access and has a private space where they can confidentially participate. It's 1 hour twice a week. So if you have patients who you think would be right for this, and especially if they're not able or willing to access conventional treatment in the office, I really suggest that you check this out. It's very easy to get patients signed up and they really benefit from it. And it's rolling admission, which is unusual. So they can just jump in when they're ready. And that's a really important piece for this population.